I'm going to be talking about etiology, epidemiology, and clinical manifestations, or I'd like to say what, how, who, and what does it look like. So before we get started, we need to have a common language. We're going to be talking about immunology and how the body responds to foreign invaders. So I thought that we would have a review. And this is the HIV immunology. And just kidding, we're not going through that slide. Just seeing if you're awake. So it's simplified. I think of things in a very simple person, and I'm a visual person, so I like to get it down to where I can understand it. So we're talking about immunology, and it's the body's recognition of things that are foreign to them, or to the body, and how to mount a defense. So there's two kinds of defenses. There's humoral, which is the production of antibodies, and then there's cell-mediated, and there's lots of different cells and different actions from each cell that occur. So where does this happen? And it happens in the lymphoid tissues, and there's the thymus, which is a gland that sits right here, the bone marrow, which is in the bones, and then the secondary is the lymph nodes and spleen. And those are the sites where actually the antibodies in the cell meet up with the foreign body. So the thymus, and this is just a shorthand, produces T cells, and if you can guess, the bone marrow produces B cells, and we'll talk a little more about that. So different cell types within the immune system are the T lymphocytes, and we're going to talk more about them. There's a whole family of different types. There's B lymphocytes, and those recognize the antigens, and the antigen is the foreign article or to the cells. And then there's accessory cells, and I think of them as macrophages, like the little Pac-Man that goes along chewing up all the foreign stuff. Killer cells, which is obvious what they do. And mast cells, you know, when we have an allergic reaction and we start itching, and that's because of the release of histamines and everything at that area to cause inflammation. So T cells are a family of cells, and I know that you can't see the cells down there on the, it's my right, on the right, but that's a T cell that differentiates it. So think of it as a family, and then the three, CD3, CD4, those are just different names of the family members. The CD stands for cluster of differentiation, and the 3 refers to the different types of proteins that are on the cell. We kind of use interchangeably CD4 and T cells, or T4 cells, pretty much the same. So people are going to go back and forth throughout the day, perhaps, talking about them, but it's really the same thing, so don't get confused about that. HIV is a virus, and just a little bit of review, you know, what's the difference between a bacteria and a virus? A bacteria is sort of self-contained cell. It can do anything it wants all by itself. So think of it as an espresso stand that you just go there and get coffee. Where the virus just has sort of the blueprints and the translator. So it's as if somebody comes into your house with the coffee, but uses all your equipment to make the coffee for you. So it can't make the coffee by itself, whereas the bacteria can, and the same thing. Viruses don't exist outside some sort of host. And this picture shows a little bit of the size difference. So definitions. HIV is a human immunodeficiency virus, and there's 2 types, HIV-1 and HIV-2. Don't see a lot of HIV-2 here. It's from West Africa, Angola, and Mozambique. The reason that it's important to know about the 2 different ones is because when we do lab tests on the virus, we look for a viral load, but if you have HIV-2, then checking with a viral load that measures HIV-1, you're not going to find the virus. So it's just kind of important to know. I've been in practice 20 years, seen many HIV, and in that 20 years I've had 1 person with HIV-2. So in this part of the country it's very uncommon. And then AIDS is acquired immune deficiency syndrome, and so it's acquired because people aren't born with it. I don't know if you remember the bubble boy. You guys heard of the bubble boy? You know, so he was born with his immune deficiency. So it's not acquired, it's congenital, just to give you a little bit of difference in why we use those terms. So HIV is an RNA virus, so it's RNA that needs to be turned into DNA. And it's a lentivirus, which means slow virus. We always think as people getting HIV, getting sick rather quickly and then dying. But some people can get infected, and it may take 2 to 10 years before they really see an effect, as opposed to you get a bacterial infection or cold, within 7 days you're sick. So, where did it come from? So there's these red cap maccabees who have a similar virus. It's a simian virus. And then we have, this is a greater spot-nosed monkey. Kind of clever names for these guys, given what they look like. But anyway, they also have a virus. And then this guy, this chimp, although he doesn't want to admit it, preys on both of these different monkeys. And so what has happened is he's eaten different ones, and what happens is a virus, 2 different viruses, and they kind of go viral, if you will, and they intermix and then have come up with this virulent form of the HIV virus. And so that's where the virus sort of has evolved from. And so how long has it been around? We've heard about it since the 80s, but the scientists have gone back and looked at serum that they've had stored, and they've found it back in 1959 and 1960 in the Democratic Republic of the Congo, some serum in 1969 and 76, and there's some other researchers that have backdated even farther than that. We've got it in monkeys or chimpanzees. How did it get into people? And there's several different theories about that. One's the hunter theory. People in Africa have gone out there, they eat chimpanzee, they get a chimpanzee that's sick, and they either eat the meat and get infected with the virus, or apparently when you hunt with knives, you often get cut yourself, and then the chimpanzee is bleeding, you get the blood into your system and get infected that way. So that's one theory. Another theory is contaminated needles. If you look at the infection, when it started spreading, it was around the time we were giving smallpox immunizations. They had disposable needles, but in Africa, where resources are limited, they used one needle for several people. So that's another way to get it transmitted. Colonialism is, back in the late 19th and 20th century, the French and Belgium went into Africa and had camps of workers, and very poor conditions. They weren't getting fed well. They weren't able to keep clean, very close environments. A sick chimpanzee may be wandering by and they ate it, and then they got infected. Prostitutes in the camps, then they got infected, and then the French and the Belgium, if they were also using the prostitutes, got infected and then went back to France or Belgium and started spreading it. So it just kind of goes along. There's 2 other theories that are out there that I'm hoping to dispel. There's one, the oral polio virus. To get that vaccine, you have to grow it in live tissue, and it's been grown in monkeys. And so there's some thought out there saying, well, if you're growing it in monkeys and they're infected in HIV, then that we're inoculating people with the polio. But the thing is, they grow it. This is a macaque down here giving you a big smile, and this is where they're grown in their kidneys, and these guys are not infected with HIV. And they can't get infected, so that theory doesn't work. As well as the company who made the vaccine went back and they had some old serum and they looked at it and there was no evidence of HIV in it, so it's not an option. And then there's another theory out there, this sort of conspiracy theory, where people think that the US government has engineered this virus and has infected people to get rid of African Americans and gays. And you think, wow, that's kind of really crazy, but if you think back to the Tuskegee studies that started in 1932, where I think it was CDC, were following poor black men that had syphilis. They didn't give them syphilis, and they had 400 that had syphilis and I think 200 that didn't, and so they were just doing the natural progression of syphilis. They didn't tell these men that they had syphilis, and in 1932 we had no treatment, so they were just following them around. In 1947 we had penicillin, which was treated. These men did not get treated, again, nor did they know that they had syphilis. And so, as you can imagine, this is a big deal, and it's very easy to think why the African American community would say, okay, here's another experiment that they're trying on us. So it's really not as wacky as it sounds, but I don't have much credence in it. I personally don't think that's what's going on. So now we have it in humans. How does it get around? There has been, I think it's Dr. Darrow at the CDC, talked about this patient O, and then the press picked it up and called him patient 0, and it was a gay Canadian steward, and the thought was that he was spreading it all over. Then there was Randy Stilts wrote a book on that, saying that this is how it got spread throughout the country. Well, Dr. Darrow went back and looked at his research and found that it was unfounded, and he felt that Mr. Stilts sort of misconstrued and misrepresented it. So I think that that theory, although it's out there, it's not true. Think about what's going on. Travel. If this is a slow virus, and most people, 1982 is around when it really became noticed. If you go back 10 years and think, well, what was going on 10 years ago? 1969, the Stonewall riots in New York, where gays were being a little bit more vocal and fighting back for their rights. So the gay revolution started then. Also, the sexual revolution started then, when we had birth control and people were being a lot more sexually active than they've been in the past. And travel also picked up, and a lot of people were doing more international travel. And as well as, this is towards the end of the Vietnam War, and a lot of the vets came back and were using heroin and other IV drugs. So you just have a perfect setup for one person to get infected, and you can see the domino effect, how it would really spread quite quickly. Also, it was in the blood transfusions, it was infecting that. And luckily now we have that under control and it's not an issue. So this is a little segue. I love to travel, and this is a picture that I took in Mombasa outside of Nairobi, and it's a billboard and it has a cachectic guy in the middle, and it just says AIDS kills, and it's just a reminder that things are out there. So I'll talk a little bit about the virus. This is what it looks like in cartoon. The red stuff is the RNA that's in the virus, and the blue stuff are different enzymes that helps the virus take over. So here's a human cell, and here's the HIV virus, and it comes up, and you can see at number 1 there, and number 2 are receptors, and here's a cell, and it kind of docks on these receptors, and there's a CD4 receptor, and there's a CCR5 receptor. I'm not going to go into that more, but when the person this afternoon, I think, talks about medications, I suspect that they're going to talk about that one spot. So the virus gets in, and you can see that's a little brown triangle inside by number 3. What happens is it releases its RNA into the cell, and then it has reverse transcriptase. So it's the RNA is the blueprint, the transcriptase is the translator that makes it into DNA using the human parts or materials. And then after the DNA, it goes into the nucleus and actually gets incorporated into human DNA. And again, the integrase is an enzyme that does that. And as you can see, once it's in the human DNA, it's very difficult for the body to say, okay, this is self versus not self. And there's no way the body's going to detect this as being foreign anymore because it's incorporated. Then from the DNA, it makes RNA, and that, again, is a blueprint to make the parts of the virus, and then it gets put together, and it buds out and goes on to infect more cells. So how often does this happen? This virus is pretty tricky. It can multiply 10 billion times in one day. Its lifespan of each virus is about 7 hours, and the mutation rate's very high. And why that's important, again, will be more evident when they talk about medication this afternoon. But I think of the virus as being those plastic beads that kids have, and where you have an orange one and a purple one, and when it mutates, instead of that second purple one, what happens is maybe a red one gets put in, and that's a mutation from the amino acids. All right, so now we've got the virus and people are infected. What are we going to do about it? So we look at monitoring. And again, I'm sort of simple and like to think of things in easy ways. So think of the T cells are these soldiers. And what happens is you want to have a lot of soldiers to protect yourself. And the CD4 count, or the T cell count, is a measure of how many soldiers there are. T cell count varies throughout the day. The percent CD4, the percent T4 cell count, is pretty stable. So some people look at that. In my practice, I don't find it all that helpful. But think of it as you've got all these soldiers on a base. Those are the ones that are active. It's always about the same amount, but there may be more soldiers in and out of the fort. So we're just looking at the ones that are active. And then the viral load is how much virus is in the blood, and think of it as bullets and arrows. You don't want to have a lot of bullets and arrows. Ideally, you would have no bullets and arrows and a lot of soldiers, which is saying no viral load and a high T cell count. But if you don't have a high T cell count, let's say you don't have many soldiers, if you only have 1 or 2 bullets, that's okay. So it's sort of a ratio of the two that's important. The goal, and again, I think when they talk about it in medication, is to get the T cell as high as possible and the viral load undetectable, and it's very easy to do with medication, which is not easy to take. So I'm going to blame this on Kathy. She wanted me to put this in, as in classifications, and there used to be a very complicated classification where it was A, B, C, and 1, 2, 3, and again, I don't do academic medicine, I just do out in the country medicine, and I didn't really ever find that helpful. This classification seems a little bit better. So you have stage 1, and I just put in the red where they are. It's around if you have 500 T cells or higher, and then I also put in the percent if you want to follow that. Stage 2 is, again, they don't have any real illnesses, but T cells are down. And then stage 3 is their T cells are under 200 and or they have an AIDS defining condition, and I'm going to come back to that in a couple slides. Pediatrics, I don't do kids, so I don't do no babies. So this one I'm just sort of going to wing it. And the way that I looked at it was, the classifications are N, A, B, and C. So I put N, that's not sick. A is they're almost well, so they have a little bit of illness. And B is that they're moderately sick or they're becoming ill. And C is that they're critically ill. They're the ones that are very sick and have advanced AIDS. So I have 2 slides on AIDS defining conditions. I'm not going to read these all to you. It's just for you to go back to look at. There are 2 slides, as I said. I don't know how to go back, but of these on this slide, there's lots of things here, but the ones that I'm seeing in my practice and people who present have the Kaposi sarcoma, they have macrobacterium, either actual TB or something called Macrobacterium avium complex, pneumocystis and pneumonia, and wasting syndrome. I had a gentleman who I've been following for years. He dropped out of sight for a couple years. He's got a crystal meth problem, showed back up, and he was usually weighing around 170. He's now probably 125, and so it's a little bit crystal meth, but also would be considered AIDS wasting, which is losing 10% of your ideal body weight. This is a billboard I saw in St. John's in the Virgin Islands, where they just say, know your status, get tested. Epidemiology, so we're moving away from what the virus is to who has it. Well, and currently there's 33 million people worldwide that have it. 1.7 million are in the United States. When I was driving down Aurora this morning, there was a billboard that said it was 1.25 million heart attacks a year, just to give you an idea of the sort of the breadth or how much is really going on. 20% of these people are undiagnosed. And this is a huge problem, and I think that the next speaker is going to be talking a little bit more about it, so I don't want to steal her thunder. This part's really kind of interesting. 1982, 75% of the people were over 50 years old. In 2006, 15% of the people are over 50 years old who have HIV. And it's predicted in 2015, 50% of the people who are HIV positive are over 50. So sort of, well, it's sort of a young person's disease, what's happening? One, people are aging in, they're living longer, so they've got it when they were before 50, and now luckily they're after 50. I think also people are aging, there are a lot of people are getting divorced and re-entering the dating field and kind of think to themselves, well, HIV is not in my population, I don't need to worry about it, I don't need to use condoms. Not so. I have several people that have come to me in their 60s that were just diagnosed with HIV. So, but when I have a divorced person in my office who's over 50 and I say, you gotta use condoms, they look at me like I'm totally nuts. And they go, yeah, sure. They don't do it, but as you can see, it's gonna be a problem, and it's gonna be more and more of a problem as there's more people over the age of 50, so there's more chance of being exposed. So this is a diagnosis of HIV, and later on I'm gonna have actually people living with AIDS. So there's a distinction between just being diagnosed with HIV and the AIDS. And this is over time, just to show you the proportion who's getting it. More males than females. I don't know why in 2009 there's an uptick of the males, but there is. This is just one point in time instead of those 4 years in 2010. And I'm sort of showing you the gender distribution, and you can see males 37,000, females 10,000, and also how do they get it. The yellow for the males is male-to-male sexual contact, and in the pink in the females, that's really heterosexual contact. So it's still transmitted in men, with men having sex with men, as we think, but there's lots of other injection drug use, or people who have, men who have sex with men and have drug use. And a lot of these men that have sex with men don't consider themselves gay, they consider themselves bi, and so then they're going back to female partners, not disclosing that they have sex with men, and that's how it gets into the heterosexual population. And this is over time, the 4 years of how the transmission, who's transmitting it. Again, in 2008, it looks like male-to-male sexual contact has gone up. And my hypothesis is, if you think about, okay, these guys, you know, the people who are getting it are in their 20s, 20 years ago, they were pretty young, had no, you know, HIV was not on their radar screen, and so they don't remember the devastation. They don't remember that a lot of the gay men from the age 30 to 50 are gone. So they think that, one, this is a curable disease. They don't think it's any big deal to get it, so they're going out and practicing pretty high-risk sex. And then this is over time by race and ethnicity, and African Americans are up at the top, followed by whites and Hispanics. And just to give you an idea, if you recall going back here, so 45% of the people who are infected are African Americans. And so you go, well, okay, what's the population in this country? And this is just general population. So 77% of the people in this country are Caucasian, but 45% of the people who have the disease are African Americans, where only 3.6% in Washington State and 12% in the country. So very high disproportion of disease by people of color. And this is just to give you an idea of where is it, the rates of people living with HIV in the country, with light blue being very low and the orange being very high. And again, I'm an internist. I see people 16 and above, though I did want to give you a little view of children, and this is where the children who are infected are living. And you can see, like in Washington State here, 2.2 versus 187. So you can see, although children have it, it's luckily at a much, much lower rate. And I'm going to come back and talk about neonatal transmission shortly. So this is over time death rates and a diagnosis of AIDS. And around 91, 92, you see it sort of really jumping up. It's not because there's more cases, but the definition of AIDS and how they were getting the surveillance changed. So you see a large jump. And then around 95 and 96, you see that the diagnoses go down. Not quite sure why that is, but the death rate goes down, and that's when protease inhibitors came along, and that made a huge difference in people's survival rate. So how much of a difference? This is just to give you an idea, to put it in a perspective. So people who have pancreatic cancer diagnosed with it, usually after diagnosis, have 4 to 6 months before they die. Breast cancer receptor negative, 17 months. Ovarian cancer after diagnosis, 36 months. ALS, Lou Gehrig's disease, 7 months after diagnoses. Congestive heart failure in males, about 19 months, not quite 2 years. So before we had HAART is highly active antiviral medication, 24 months. You got diagnosed with HIV, you probably had 2 years to live. But after we got the medication, it went up to 300 months. It's 25 years. So luckily, we've made a huge inroad into survival, which is always good. So these slides are people actually living with the AIDS diagnosis, not just HIV positive. And since they're living longer, you would expect as more people get infected, the numbers are going to go up. And instead of staying, if it was a straight line, you would say, okay, people are dying and then people are being infected and replacing them, but that's not the case. There's more. So again, it shows that people are living longer. And this is the same thing by ethnicity, and you can see that, again, these are actual numbers, not percentages of people living with HIV, and you can see that, again, the African American community has the biggest burden of this disease. And this is over time on how transmission, who's getting it from how, and again, you can see the male-to-male sexual contact was going down for a while. I think that was information after, the plague and losing a lot of gay men. But again, the collective memory is very short, and so now it's going back up again. And I think the injection drug use is going down, hopefully for needle exchange, which is being pushed throughout the country. So what about babies? There's babies born to mothers who are HIV positive, and this is the number of cases over the years, and you can see again it sort of peaks 93, 94, and then drops down when we have protease inhibitors and other medications, and a better understanding on how to help keep transmission from occurring. And then down in 2002 and 2003, the numbers are so much smaller, so I kind of just pulled them up to show you. So this is in the entire United States. In 2001, only 118 babies were infected. And it's dropped down, and I'm not sure, just statistical variation on why it went from 50 in 2004 up to 67 in 2005. But it's still a pretty small number. Many of these may be from women who didn't know they were positive and came into care very late in their pregnancy. Okay, what about here? What's going on in Washington State? First case was in 1982. At this point, over 18,000 have been diagnosed with HIV. Right now, 11,000 are reported living, so what's the discrepancy between the 18,000 and the 11 is probably people who aren't living anymore, and then they've died from it. And it's increasing about 5% a year. We need to work on education a little bit better, I think. Between 2006 and 2010, the new cases have been stable, but there's still 560 people being infected each year just here in Washington State. And 16% have not been diagnosed, and this is a problem. They're getting into care late, which is difficult once the T cells get down. Somebody has a T cell or 10 or 20, it's very difficult to get it up higher. Ideally we like to see T cells above 500. Normal, someone who's not HIV positive, T cells are around 600 to 1700. There has been a study recently that showed that if you have 30% of the people that are positive in a community treated, you can decrease transmission rate by 38%. So it's important to get people into treatment and on medication, because that also is a preventative on spreading the disease. Okay, so where is it in the state? This is not going to be a big surprise. In the middle is King County. Snohomish and Pierce also have a large population, and then it sort of drops off the farther you get from Seattle. And this gives you an idea of, over the last 10 years, the AIDS cases are in the middle. The top one, who's HIV, and remember I said these are new cases, and they're still 560 a year, and that's what that shows. The middle one shows the AIDS cases, and hopefully I'd like to see that dropping, because as people get into care, then they're less likely to have progression to AIDS. And so that's a good thing, as well as the death rate is going down. I would say in the last year, my practice, I have about 150 to 200 HIV patients, and I've lost 2 in the last year, which is, I mean, it's kind of nice that I can even tell you how many I've lost. And one was from, he had hepatitis B, and so he died from actually hepatitis B, liver cancer. And the other gentleman came into care so late that I couldn't get control of. He had Macrobacterium avium complex, and just not able to get control of the infection. What about people who are living? And this shows you people living, again, since people are living longer, not dying from AIDS, you would expect the number to go up each year. And if you can measure it, though it's a little bit hard, each year the number of people with AIDS is getting bigger, but again, we have such better medication and treatment that these folks are living. I had this one guy came in for his office visit, and we were done, and he was getting ready to leave the office, and I'm walking past him, and that's where you always get the best information. So my hands on the doorknob, opening the door, it's like, oh, by the way, he says to me, I'm really tired. I'm thinking, wow, what's going on? He goes, I am exhausted. I said, well, why? What's going on? He said, when I get to that second game of soccer on Saturday afternoon, I can just not get through it. And I'm thinking to myself, that's great. I'm delighted. It's not something I would have heard 5-10 years ago. So if people are actually able to live normal lives.